The world's best physios don't just treat, they coach. Here at the Physio Coach Podcast, we invite the best physios, coaches, and health experts to inspire you on your journey to becoming a physio coach. This podcast is sponsored by Better, provider of in-person physio and personal training services in central London. We help people feel better, then live better. We believe that better never ends. This podcast exists to inspire your journey to better.
So high performance environments tend to stimulate innovation. They tend to promote change, and they're looking for every little inch and every little margin of progress. The Dave Brailsford concept of those kind of micro changes and micro improvements of just looking for the 1%ers all the time. That's something that the marginal gains we've heard of that before, and that's where really sports medicine consultants came from. They came from the high performance environment of sports. And what we're looking to find there is why has that been so successful? So today we've got Dr George Bownes speaking with us today, sport and exercise medicine consultant. We will challenge that label as well, that job title a little, and for the good, I think. You spoke to me the other day and opened my mind to a different way of thinking about that role. But firstly, what are the positives that we get from the origins of the sport and exercise medicine consultant for you and the way that you practice?
Yeah, sure. Thanks, Charlie. I think physiotherapy and sports medicine are different, but they're aligned. And I think that's a sort of important starting point. Physios are highly trained in musculoskeletal medicine and musculoskeletal movement and the movement mechanics and injury and injury management, all that goes with it, which is great. But doctors have obviously had a very different upbringing, if you like, through their university years and their basic training. So they're getting education across the spectrum. And so therefore I think there's a good space there for these two specialties to come together, because patients haven't read textbooks. And, you do see lots of very clear-cut pathology, if you like, coming through, which is helpful and that's great. But what happens when you get stuck, or what happens when you as a physio are providing treatment and the patient just isn't quite responding in the way that they might think or that you might think? And that's where having someone who's got a broad understanding of healthcare and health and injury and illness is helpful to then work with and then collaborate with and bounce ideas off, review patients, and collaboratively working therefore to actually improve an outcome, because a lot of what we see is stuff that gets missed.
And then we're going to spend the episode essentially unpacking that very situation, is that many physios get stuck, and that's normal. We shouldn't be expected to solve every problem and know the answers to everything. That's ridiculous. We know that makes sense. Yet in those situations where we get stuck, many people, and I'm thinking of myself certainly in my earlier career, we sit with it for too long. We don't really know the answers, and yet we keep trying the same thing and getting the same results, which is no response, not getting better. So at that point, patient either goes somewhere else. In fact, they almost certainly go somewhere else, but they might even just give up entirely, which is a terrible idea for most situations where someone's suffering. So therefore, we should embrace this idea of developing our network to include non-physios. That's obvious when we say it out loud, but in practice, many people don't do that. The other situation here in private practice, to refer out, what if that means that they don't come back? If you're self-employed or you're on a commission, what if that means that you're losing out on that business? So someone who's thinking more short-termist, maybe gets a little bit stuck and is a bit guilty of thinking of the finance of the situation, they might not refer out because they're worried about it not coming back. I definitely thought that at times, not so much in commission roles, but more in like my own ego situation of, I don't want to refer this patient out and then they disappear altogether, because I want to know what's happened. I want to help this person through this process. So I want to work with someone. I don't want to just send them out and then off they go. I want to work with someone, which then opened my eyes to this idea of networking and finding trusted specialists within the different fields, such as sport and exercise medicine consultants. since working in a pure sports medicine directly alongside consultants, it totally transformed my practice, made me more like an MDT professional, more collaborative, and my practice hasn't looked back. Right, I really see the benefits now of that. So what is a sport and exercise medicine consultant, if we try and just distill that?
Yeah, so the way I describe it to patients is, we are non-surgical doctors specialising in bone, muscle, joint, tendon injuries as a kind of elevator pitch. But to expand on that, if you look back to the history of sport and exercise medicine, so the funding for it from an NHS training point of view came out of winning the Olympics in 2012. So you go back to 2007, part of the Olympic legacy was around how you make more people in the UK population more physically active, and therefore we need to have the right healthcare professionals to look after them. So it's the exercise element actually that got sport and exercise medicine its funding. At that stage, it was people who were basically doing it as mainly GPs who had then done extra specialist training, such as postgraduate qualifications that were practicing. But that led to a formalised training program that then accelerated on from there. And now you have various people who do various subspecialties. But I think from a branding point of view, if you like, musculoskeletal medicine physicians or doctors would be a better understanding, because for a GP, for example, a third roughly of what they see is musculoskeletal issues. If you're a management consultant, you're going to organise GP training, you'd say, well, therefore you need to spend a third of your time in your 3 years of training doing musculoskeletal stuff. And most people probably don't even do 2 weeks. And that's because GPs are working much more around bigger issues, should we say, in terms of cardiovascular health, respiratory health, cancer awareness, all those sorts of things, COVID in more recent years. So they often would say, just go to physio, as if to say, just going to physio is just going to solve everything. And we know that's not, physio alone is not 100% going to answer that. And therefore, actually, sport and exercise medicine or musculoskeletal doctors, I think, are much more kind of gatekeepers to essentially triage, see what that is, investigate if need be, and then send on to the right appropriate people at the right appropriate time. Surgeons, if you like, they love working with people like myself, because if they get a patient coming from us, they know that they're well packaged and ready to go from a surgical point of view. They want to sit in clinics and see lots of cases that either are about to have surgery or maybe having surgery a little bit down the line, but are nicely positioned, and they could have well have been pre-op optimised by physio. Think of a joint replacement, for example. Equally, they don't want to sit there seeing lots of people that they can't do anything with, and then they would go, we'll just go to physio again, as if physio is just going to magically solve it. But actually, there's lots of things that we can do that are non-surgical, injections, for example, loading programs, working with physio, bringing in other allied health professionals, thinking podiatrists maybe, or osteopaths, or strength and conditioning coaches, as sort of easy wins of people that are nearby that we can work with, that really sort of help to move people on, particularly when surgery is not the option for them. Or we then get to see the sort of reverse of that, which is lots of people coming in going, I've been doing my physio, but I'm just not getting better, which is exactly what to your point there of sometimes one person just looking at one patient trying to solve all their problems just doesn't quite allow that to happen, and you get a blockage between you as a practitioner and you as the patient, or the patient gets a blockage between you. And it's not that physio's wrong, it's just that maybe there's a few other bits that we just need to work on to allow them to access that rehab a little bit more. Yeah,
I fully agree, and that's where my thinking is these days. But I know you through your work with Citius. You run Citius as an organisation, and you seem to be this kind of super connector. You collaborate. you love to work alongside loads of people, and networking clearly is a big part of what you do and the success that you've achieved. Where did that come from? Where did those skills originate?
For me, I think sports medicine is a team sport. Okay, so I've been really lucky in the way that I've kind of come through my medical training and the things that I've done as I've finished my medical training, in terms of working in the military. So worked at Headley Corps, was involved with that transition up to Stamford Hall, worked a variety of regional rehab centres. And in those environments, you've got, you sit there for an MDT approach for a patient, you get 1 hour, and there's about 7 or 8 people in the room. Now, I don't need to sit there and ask all the questions. It's almost like I've got to keep everyone else in the room engaged and entertained and be able to know them to go and bring out their specialist knowledge on how that's going to help that particular patient. And then you get to bring them in for residential rehab, which can be 3 weeks at a time. So you get to spend really good quality time working alongside really good people. And as a result, the outcomes are better. And particularly when I was there in Headley in 2012, it was absolutely rocking. The Queen came, which was amazing. Prince Charles came. So it's getting a lot of attention because it was very busy at that time with not just wars and battles and things that were going on, but also day to day in the military, they're very busy injuring themselves and doing it in a big and spectacular way from their training. So it's always a busy place, but they've got, an amazing setup there of practitioners, but also facilities. And therefore, it's a great place to be. And there were lots of sports medicine consultants there to learn from. It was a super enjoyable space. But then also following on from that, working with Olympic athletes. And again, as it was the England Institute of Sport, now the UK Sport Institute, they've got a huge array of offerings across healthcare and coaching, and lots of psychology support, for example, and mentorship, and all that goes with it. And those offerings are also given to the staff just as much as it's given to the athlete. So the whole environment moves along, and that's why you often see people maybe start as a physio and they transition into more of a management role as their career develops, because they're picking up all this learning, and it's such a well-supported environment. And then fast forward to stuff that I've done with rugby, having spent some time with age group teams as well as England, the Red Roses for a period of time, and then mainly with Harlequins, where we worked through that COVID season really well as a group. A lot of us had been there for a long period of time and worked with the athletes from a long period of time. And then to win that premiership off the back of that with all the disruption in the background, I think was a massive testament, not just the players, but the support staff, the owner, all the team together, coming together. And therefore, now that I'm not so much spending time in sport, the Citius Retired Athlete Programme is a way of essentially continuing that work with, in many ways, a lot of those same athletes, but also opening that out to wider sports as well, but also just trying to bring that ethos through. I don't want to sit in my clinic room on my own, one-on-one with a patient, when I know that to get the best outcome for that person, you need to bring in a community of people. And it's all, everyone's different. And so, depending on where people live and what their aspirations are, you want to match them with someone that they're going to get on with. And there's, a lot of what I think that I like to try to achieve anyways is aligning that particular patient with someone that they're going to get on with for the goal that they're trying to go after. And their goal might just be, I just want to walk around and be happy, or I want to play with my kids, or maybe I want to go and do an Ironman, or I want to go and do some stages of the Tour de France, etc., etc., etc. But you can find somebody that's going to work with them at their level that they want to be at. And I think that's great.
The retired athlete's an interesting person because they would still identify hugely with the athlete they were, and they're very used to having healthcare wrapped around them, very used to having support, and all of a sudden they're left stranded to some degree. Some of them, I imagine. I know there are systems out there to help them kind of bridge the gap between their playing days versus their retirement. But many of them have injuries, many of them have problems. Tell us a bit more about that program and how you aim to support the retired athlete.
Yeah, exactly. I think the Olympic sort of situation is probably quite good because you get a degree of kind of runoff. Once they say they're going to end their funding, they get a few months. Similarly, kind of the military get the same period of time. But after that, you are then, as you say, left to your own devices, as it were. And as I've come through my training and come through the work that I've done, you meet physios, for example, who again have followed a similar journey where they've. I was talking to a colleague who works at a Premiership club, football club now, having left Premiership rugby. He's been doing top end Premiership football for the last 4 or 5 years. He's going to have a period of 6 months out. So he's asking me about, how do you go and, work in the private sector for a period of time. So giving him some advice and people to go and speak to and connect with. And his point back to me is, it's very different, isn't it? I said, yeah, it is very different. And actually navigating that space and then working out who are the good people to work with, it is tricky. And so for an athlete, where they're exactly like you say, they're spoon-fed in that sense. They're wrapped around with this incredible care. They've got someone on the phone 24/7 if they needed it. They then struggle a little bit. And that's kind of where... and also where some of these guys have gone on to set up health and wellbeing brands. I use Joe Gray at MyoMaster as an example, so recovery brand. Great to work on a project as we are together, the Retired Athlete Programme, with Arthrosamid made around knee arthritis and trying to keep knee function as good as possible, and the positive impact that then has on overall health. But then, wrapping in things like using the MyoMaster products on how that then improves your recovery and maintenance, etc. Another project I'm working with Matt Simmons is around executive coaching, and so taking a desk-based athlete, if you like, an senior executive who's looking to drive their company forward, and how do you then apply those principles from sport and that wraparound care to make that C-suite level executive more efficient at their job and have a better family life and a better balance, so they can sleep and they can eat and they can start moving their bodies. And I think, you're looking at that work that Matt Simmons has done there in that executive coaching, where he's brought in doctors and he's brought in sleep people and nutritionists, and using things like Whoop and all that kind of, easy to access tech, really improving outcomes. And they're actually seeing massive positive benefits in their actual performance at work as a business, because they've taken this MDT approach. And so that's another way of nicely combining that athlete environment with retired athletes, but also that athlete appreciating what they had, and then they want to try and mimic that as well. So there's good sort of synergy and community on that.
I also want to come back to another point that you mentioned earlier about the label of a sport exercise medicine consultant not necessarily fully aligning with the day-to-day work that you do, and it feels to you more like a musculoskeletal doctor's role. And when you said that to me in our talk before the recording, it was like a light bulb in my head. It was like, oh yeah, it is definitely more like that, isn't it? Like the legacy of the sporting origins makes sense, but it isn't so much about what you do anymore. I mean, of course you have athletes involved, and sports is part of it, and exercise is part of it. But when you really distill it down into what it is on an application perspective, it's musculoskeletal medicine, right? Musculoskeletal doctor.
Yeah, exactly. And we do get patients who sometimes come in, actually probably about once a week, and they go, I'm not like your athlete person. Yeah. I was like, no, but you move your body. Everyone needs to move their body. That's what we're designed to do. So on one level or another, you can class yourself as an athlete. It's just that you maybe haven't honed those skills quite as much.
And I think the powerful bit here is, because of that exact situation, is sometimes it alienates the patient who isn't an athlete.
Yeah.
And they think, sport and exercise medicine consultant, I'm not really sporty. I don't really need to see them. But when you label it as a musculoskeletal doctor, I have a musculoskeletal problem. My physio is a musculoskeletal physio. I now need to see a musculoskeletal doctor.
Yeah, exactly. Because we know that, if you go into hospital environments, for example, you've got respiratory physios, etc. But in the general public, when they say physio, people generally think that's musculoskeletal without necessarily putting those words out there. Yeah.
So what do you then see on a day-to-day basis? What's coming in through your door? The typical stuff that you're doing?
Yeah, I mean, if I did a clinic this morning, talk about a few of those patients. So interestingly, a lot of reviews today, but one chap, 24, marathon runner, mid-thigh pain, having physio, it's not getting better. And for me, I was like, this will probably be a bone stress injury. And I appreciate that's not where most people would see a bone stress injury, but the sort of stuff that comes through our door and the way that he'd, been having some physio input and it wasn't making any difference. And whilst he could do activities like cycling and use of elliptical trainer, he can't run. And then he's getting pain afterwards. Like, well, this all sort of looks like it's going to be a bone stress injury. We've done an MRI this week, comes back, and, unsurprisingly, he's got a bone stress injury. So we see loads of those types of things, and not necessarily always, medial tibial stress.
Let's think of that case in particular there, because I know in my mind the thing that would flag up to me is that I would be looking at things like tolerance of impact, like a squat versus a jump versus a hop.
Yeah.
And does their pain escalate in accordance with a bone stress versus a muscle injury? Also, the mechanism of injury. Was there a clear muscular trauma? It's just things I'd be thinking of. And also, like, has it got better in a time that a muscle would get better? Muscles heal incredibly fast. They have really good vasculature, so they tend to heal quicker, but the cell turnover is faster. Bones heal a little more slowly. Ligaments slower again. Cartilage even slower. So these are the kind of things I'd be thinking of. Is there anything else there that you'd be picking up on as like stuff that your spidey sense starts to tingle? Those cases?
One of my big ones is there's a lot of runners flying around at the moment. Obviously, autumn marathon season and various other distances that people are doing is, where are you getting your training program from? And as soon as people start saying, I'm using my watch, I've got experience, and all this kind of stuff, or, I hate to say it, I use the Runner app. They're probably one of my biggest referrers at the moment.
Yeah.
And there are better apps out there. Reference the Cooper app, used by the London Marathon, but it's written by international coaches, and therefore, there's more chance of people reducing their injury risk, which is important, because I think where this chap I was saying about with the thigh, he's 24, so he'll probably be okay to not necessarily run for a couple of weeks. But if you're someone into their 30s where you've got a young family and you've got a stressful job and you're trying to raise money for charity and all that goes with it, and you feel under pressure, but you're also using running as a way of balancing your life, which a lot of people do, to then say, look, you're not going to be able to do this and all that goes with that, probably has a bigger impact to them. Different. I'm not saying that it doesn't have an impact for the 24-year-old, but the individual that you're looking at, when you have to then modify your activity because of an injury, can have really big repercussions, and we all know that. But we see a slightly different side of that, if you like, or certainly people start talking just in a slightly different way about it. So training errors, if you like, and how to mitigate your risk, I think is a big thing that we can support physios on, and patients, education and knowledge.
What are the typical things that you would have a conversation with around this case in particular?
So just starting by understanding what they know, ideas, concerns, expectations, from that individual, but trying to propose ideas that they may have thought about or may not have done. Are they using vitamin D, for example? Are they eating a good diet? Are they, what's their, are they using the right footwear? Another classic one that will affect anything through your biomechanical chain. Are you just running? Are you doing all some cross training and other bits that go with it? How are you running in terms of where are you doing it? Do you do it in a club, or do you do it on your own? Are you doing it in pavements? Are you doing it in parks? I think it's interesting. I've seen more running injuries this autumn than I normally would do this time of year. So I think that potentially that's because more people are running. I think some of that data coming out from various sources suggesting that running is again becoming more popular as an activity, which is interesting. So I think therefore we're going to probably within all of our clinical practices see more running related issues, which will be interesting again. I don't know, there's probably a number of reasons for why that might be the case, but normally we tend to see more people in that spring period where they've been running over the winter.
More events as well these days?
Yeah, I think so. So I think just exploring all of those things and trying to get that patient to be thinking a little bit more around why they might be getting injured or how they can do things slightly better. I don't think we see quite as, it used to be that kind of couch to 5k crowd, if you like, and I'm not saying those people aren't out there still, but actually more people I'm seeing now are more people who are sort of 10k pushing on.
It's also the run club crowd, isn't it? because of the community attached to that. People are more likely to be following someone a bit faster than them, perhaps a bit more peer pressure. The Strava environment drives people towards personal bests all the time, and trying to push harder than perhaps they should. The other thing is this perfect storm as well of people wanting to run more because they're seeing it and they're inspired by others, but also wanting to look the best. So there will certainly be some people who are training harder than they would normally train and eating less than they perhaps would normally eat, which then opens up the conversation around REDs, doesn't it?
Yeah, and I think also all the GLP-1 stuff as well. We're seeing a lot of patients who are losing weight rapidly, and a lot of that being muscle, not just body fat. And then the loading that they're doing with that and the changes that's happening, particularly more kind of tendon issues than anything else. Tendons and knees. So Achilles, patella, and knee issues. Majority of what I'm seeing. I mean, I saw a patient the other week and he lost 1.5 stone in 3 weeks, and he's a big chap. But it's like, no wonder your body's, almost in a state of shock, if you like, of what's going on, and various parts of your knees and your hips are kicking off as a result of it. So there'll be a newer wave, I think, over this winter of people who are presenting perhaps slightly differently.
Why do you think the tendons are taking the strain there?
I don't know really, but I mean, you'd think that obviously they're trying to essentially reduce the load by what they're doing there in terms of trying to reduce the weight. But I think there's maybe it's part of the nutritional deficit that they essentially go into as part of it, and maybe it's just we don't necessarily know the answers because these are newer products that haven't been around for that long. Not to say they haven't got a place, but I think I was speaking to 2 women's health GPs yesterday, and they're seeing a lot of they're dealing with a lot of women in the menopausal time frame, and a lot of people therefore going onto that product, and they're seeing a range of musculoskeletal issues coming back to them. So they're asking me what I thought about it. I was like, I think we just don't know. I think you just need to almost kind of see a volume of patients to see what the patterns might be.
And we're talking about Ozempic, Mounjaro, these products, aren't we?
Exactly. Yeah. Which are, they're readily available.
Yeah.
People can get them off the internet. And I think that's that people's access to information on the internet and products they can get on the internet does then make it even more challenging within musculoskeletal health and medicine, of which physio is part of it. And I think we're going to see, it'll be interesting to see what we do see over the next 6 months, because I think we're going to see some slightly odd presentations of things. I know, I've got a patient this week he's been taking Mounjaro and he wants to have PRP for his tendon. I was like, okay, well, we need to probably just look at what other medications you're taking as well, because that will affect potentially the sample of PRP that we're going to be able to produce for you. So I'm just going back to Arthrex on that with a few questions before we kind of proceed. But yeah, so I think it's that's a new dynamic within musculoskeletal medicine that will be interesting to follow.
And we can't also shy away from the reality that it's likely causing a huge amount of benefit to someone's health by reducing the systemic load, both biomechanically and physiologically. People are probably on average healthier by losing the weight that they do in that way. I'm not fully convinced yet as to whether that is the best way of achieving it. Probably, well, it isn't. But if that is the way that person can achieve it, because they've tried exercise before, they've not been able to commit to it, they've tried traditional weight loss diets, they haven't been able to see the results they wanted. So I'm also trying to see this through the positive lens as well, that a huge amount of health benefit comes from losing weight. And if this is the way that gets them started, I think it's our job as healthcare providers to then support someone into the next phase of it. And that's the bit I think we're still figuring out, is how do we support someone in that journey to optimise their outcomes, to minimise the musculoskeletal injury risk, or or rehab the musculoskeletal injury, or treat whatever it is that they're coming in to see you for. So I'm also really keen to see it through that lens too, that it's not just a problem we have to solve, it's also a benefit that we're potentially seeing as well.
Yeah, I think for those people who are significantly overweight, that's one element. I think also they go back to that run club concept that you were talking about. People who, there's a lot of information recently about, are athletes going to be using it in a way of chasing that extra couple of pounds they want to try and lose, particularly maybe in an aesthetic sport or a weight defining, a weight important sport, and using that as a way of making weight or improving their aesthetic appearance. And those are those people that will then, be potentially overloading their system, trying to do more training on the background of also taking that as well. So I think there's almost like there's like two sides to it in that sense. And because it's readily available, people may not necessarily be so open about saying that they're using it. And so I think that sort of, as I'm sure everybody asks, what medication do you take? People may not see it as that, or may not want to admit to it. So I think that's where I mean in terms of that interesting dynamic of what we're going to see over the next 6 months, I think, for patients. So I think it's something to really kind of almost be, you have to ask them specifically about it, and they may not tell you the first time, so you might have to ask them again.
Yeah. And what other common presentations do you see? And I'm most interested today in things that physios miss, or stuff that physios can't treat or assess for. So what other stuff do you find?
So we talked about bone stress injuries already, and we talked about that mid-thigh one. I see loads around the hip that get missed. So that's one particular element, if you like. And then if we're thinking around, significance of muscle injuries, I've had 2 really high grade hamstring injuries come in this week that are, you see those a lot in sport, unfortunately. And we always try to get those linked in as soon as possible, because the surgical window for operating is quite small.
This is something that's shifted in recent years, isn't it? That a high-grade hamstring strain will be surgically operated on rather than rehabilitated now, almost as a standard process in sports. Why did that shift happen in recent years?
I think, there'd be a number of factors, and depending on who you are in terms of as an athlete and what sports you're playing. But I think they're looking at, it's all about getting you back on the pitch, or back on the sporting arena. And where they've had success on operating quickly, it just reinforces that that's the practice that you go down. So I think, these 2 examples I gave you this week, I was straight on to the surgeon. Can you have a look at the imaging? Can you give an opinion? If you just give them, this is the history, etc., etc., and got them actually both across to surgeons. And one's getting operated on, one's not. So it's not a case that just because we're going to send you to see a surgeon that you need to go and have surgery, partly because of perhaps the grade of the injury, or even someone with very similar injury, it may not be appropriate for you necessarily because of, say, age or your sporting expectations, etc. But again, that's a good bit of that MDT approach where we're linking with radiology, sending it to a certain radiologist who looks at more of these images. So not just an MRI, and therefore getting their more specialist opinion on it, and then getting it into, again, this is a pretty niche area, so there's only certain surgeons that will do it, and therefore linking it in with them efficiently and getting a result back efficiently for the patient, so they can start the rehab process. Because for one of them it's we're going to surgery, and for one of them it's we're going to go down to physio line. So then it's great, let's link you in with an appropriate physio, an appropriate program on what that's going to look like, rather than one of the guys had been to A&E and they'd had an x-ray, it was normal, and they get sent home in a pair of crutches. We see a lot of people who come in that sort of week 2 to week 6 period post an injury, but fortunately he'd only just done it on Saturday and he presented on Monday morning. But I wouldn't say that's common. But if he was the case that needed the surgical input, and he's presenting at 3-6 weeks down the line, that window of opportunity is pretty much gone because he'd have had too much muscle retraction, etc., etc. So that's where sort of timely use of sports medicine and musculoskeletal medicine is helpful, and that's where we go back to what we're talking about in terms of educational piece around whether that's a GP, whether that's people working in A&E, whether that's wider community knowledge of services that are available out there for you, basically.
Yeah, I think that wider knowledge this is where it does trickle down from sport, because I'm an Arsenal fan, and last year 3 Arsenal players had hamstring surgeries. Saka, Havertz and Gabriel all had hamstring surgeries. It was the first time I'd gone, wow, there's a lot of hamstring surgeries happening in sports that didn't happen before. And then you reflect on it and you think, Michael Owen's career was essentially destroyed because
it was all about hamstring.
Because hamstring injury wasn't appropriately managed at the time. They did the best based on the knowledge they had, no doubt, but it's moved on. Maybe his career would have been, in fact, I'm confident his career would have been very different if his earlier hamstring injuries would have been managed differently. I'm sure he would feel the same way. I've heard him speak very openly about his struggles with that. So then you can see how that information trickles down into sports medicine consultants, then into general musculoskeletal care, into the physio world, like me, watching that situation unfold and realising, okay, I've seen a few more surgical repairs in the last 5 years than, in fact, I don't think I ever saw one before that process as a physio. So clearly there's a bit more happening, and it's not just the tendon ripped off the bone situation. It's actually a muscle belly repair, something different to what we'd have usually seen. And then the person out there is probably like, well, that sounds expensive. How am I going to get that on the NHS? The truth is, it's probably not going to happen on the NHS, is it? It's almost certainly not going to happen on the NHS. So we're speaking also about the cost implications of getting high quality care, the appropriate care for you. People are more committed to spending on their health, but there's still a barrier. We will also speak about insurance today, and maybe it's part of this conversation here. Health insurance doesn't mean the same thing for different policies, for the same thing for different companies. So we don't work with all insurers in our business because they don't pay physio very well. So therefore, Bupa, Vitality, AXA, Aviva, we don't work with those because they don't pay us particularly well as physios. Does that then mean people that are seeing those in other practices are getting more likely to see a newly qualified physio who isn't quite so experienced with that? So this very simple thing around hamstring surgery or rehab opens up all sorts of other conversations here around accessing high quality healthcare if that's the way you want it to be. I feel like it's not even a question here, it's a statement. But how do you help someone with that scenario? Someone's come into you, or maybe it hasn't even come into you. A friend has said to you, I've had this high-grade hamstring tear, what do I do with it? Because at this point, they've not necessarily... Because even your service, to some degree, is an expensive service for some people to access if they haven't got it covered on their insurance. So a friend has asked you, how do you help them navigate that decision?
Yeah, I mean, fortunately, it's not something I get phoned out about every week, shall we say. But yeah, so I mean, go back to what I was saying before. You want to get the right imaging, and the right imaging inevitably is, yes, you can do an ultrasound, but ultimately you are going to get an MRI. So if you can access that, but then it's getting it reported by someone who looks at them, a lot of them, ideally, for which I'm very fortunate to work with people who do that. And then, as I say, then think about what the onward management is, because a lot of people can think they've got a high level injury, but actually they necessarily haven't, which is a good thing. But for when those people, when they've done it and they know they've done it, and you've clearly got all the hallmarks when you look at them, or you get sent a picture of them, significant bruising, significant muscle deformity, and all that goes with it, and you're like, well, this is essentially an emergency. I remember when I worked at Chelsea with Brian English, who was a fantastic kind of mentor at the beginning of my sports medicine career, and he talked about the significance of high-grade muscle injuries, in the sense that if you imagine you peel the skin off and have a look, you've just ripped a very, well-supported muscular structure. You're full of capillaries, massive blood flow going to it because you're doing sport in the first place, your heart rate's up. You are hosing blood all over the place. So if you saw that and it was an open wound, you'd be putting lots of pressure on it, giving it lots of treatment and then lots of attention. Because it's a deeper structure that you can't necessarily physically see, the skin in the way. Sometimes those deeper structures take time to show, the bruising that goes with it. You maybe underplay what it is. A lot of hamstrings. I made a LinkedIn post. I don't know if you saw it, but Sports Day Dad.
Yeah.
And this year was Sports Day Mum. I saw more Sports Day mums than Sports Day Dads. And again, those are injuries that are often super high grade and very much on the cusp of needing surgery. And some of them go on to have surgery, but only if they're presenting quickly. Again, they're classic ones where they actually get left a bit too long. A lot of the time they're coming in at that sort of week 2, week 3. The two I spoke about from having seen this week, they were both, one was football, one was rugby, but they basically did it at the weekend and they're coming in at the beginning of the week, which is great because you've got more opportunity to then line up, appropriate options for themselves. So again, go back to your question, what the advice you give is like, you've got to get appropriate imaging. But also don't be afraid to, I think this world of self-pay you talk about there, we do get a lot of people who just turn up and go, well, I've had my MRI, or the converse of that is my physio sent me in because I want an MRI. It's like, well, we're not just an MRI service, and not all MRIs are the same. I don't just mean whether it's a 1.5T or a 3T. I mean the person who's then interpreting that image and what the image looks like. You can't just go on the piece of paper. You actually need to look at the scan and make sure that everything's fitting together from a history examination and what have you point of view, that the imaging then is supporting that. Otherwise, that's the same for any particular injury or issue. So yeah, I think go back to the point, get some investigations ideally, yes, in a timely manner, and then don't be afraid to get a couple of opinions. And to go back to what I was saying there about the surgeon that I work with, most often anyway, with these types of injuries, we work within the same organisation, so it's easy to share information, but also it's helpful for the patient on that journey, I think, because it's a long rehab. And so actually, for most people, getting back to just walking around is the important thing, and then sport is a longer term, goal, particularly if it's going to be multi-directional. It does take time to get back there, but if they've at least spoken to a surgeon, they then feel reassured that, I just need to really invest in my long-term rehab, which is going to be physio-focused. And then you're managing that person's expectations quite nicely. But equally, if it is a surgical case, they're going to be so grateful to you that you've given them an opportunity, because otherwise they do end up with often a bit more of a suboptimal result, basically.
Yeah, I've seen deformities, I've seen massive weaknesses, inability to sustain any kind of running program, definitely not be able to sprint from huge high-grade hamstring strains that have been perhaps not undiagnosed necessarily, but not specifically managed as that big of an injury when it first happened. So I think there's some really positive changes that are happening around the management of this. I think I just look back on regret now at my kids' schools not doing sports day races, because I've been training my whole life for that. And they don't bloody do it. But maybe my time will come in the future.
You just got to keep pushing on it. It's got to keep pushing it. I said to the headmaster at my kids' school, I was like, well, maybe just do it as a relay. Maybe do it with barefoot on grass, just to slow everyone down and just not get that traction. Try and reduce your injury risk. It's a
good idea. I really like that conversation around hamstrings, because it's definitely a hot topic at the moment, and one that you clearly deal with better than a physio, because we can't see. There are some signs. I think there are some signs: the deformity, the level of bruising, the time it takes for them to be pain-free walking. I think is quite a good indication as well. Yeah. There's some good stuff that we can look out for where we might think, okay, this high-grade injury needs to go and see a musculoskeletal doctor. I think that's a good idea. What other injuries then? What other injuries do you think physios need to have a bit of a look on for, or refer out if they see?
Yeah, I think it's more kind of, I suppose it would be things that aren't responding in the way that, it's one of the things you said at the beginning, if something isn't responding in the way that you'd expect it to after a couple of sessions, look at how you can then connect them with somebody else to get an opinion on it, because it doesn't make you a bad physio, it makes you a good physio to go and collaborate and to go and keep the patient engaged, because that's kind of also your slight duty to the patient, if you like. And I've got that, myself as a doctor, how do I give you a management plan as a patient that you're going to want to engage with? Because if I just said, right, you've got Achilles tendinopathy, copy paste, here's the management plan, then that would make life, well, it wouldn't be easy, it'd be really boring. But at the same time, they're just people aren't going to stick to it. You've got to give them a plan that's going to work. And I've got a patient this week who I saw 6 months ago with his Achilles tendinopathy. He just wants to run 5k a couple of times a week. He's in his mid-50s, but he does quite a lot of walking. He does a lot of the London historic monuments tour guiding. I was like, wow, that's quite cool. He was telling me all about all these various places during his treatment. So he'd had radial shockwave therapy. He then went on to have PRP, and he got 6 months of improvement. But he's then also gone through a period where he's put a bit more weight on. Didn't run for about 6 weeks because of various things that were going on, but just did a bit of line biking. And I said, well, it's not quite the same kind of effort. And then he's gone back into running, but he hasn't really followed a program despite advice, and so his tendinopathy's come back in quite a big way. So again, we've now got to come up with a plan that's going to work for him, but also going back to your other question around insurance companies, getting them to recognise that there's a difference between focal and radial shockwave. So I'm trying to get them to have some focal shockwave and go and see a different physio who's a bit more running focused, who can also provide that, because that service isn't necessarily available as freely as radial is. And
can you, just on that point, can you tell the listener what the difference is? Because I only realised the difference a few years ago.
Oh, well, you can tell me. I mean, the way I describe it to patients is, you've got a big head and a small head, and the way that you can then focus that in. So the radial has the smaller head, the penetration isn't quite so far. The focus can get much deeper penetration. That's where it's come from. There's people use it to break up things like kidney stones. So it's very effective, particularly for those more resistant tendons. I think it works well with Achilles, particularly because it's such a big tendon, and you often get these bounce backs from patients down the line. And I did say that to him. If we don't keep it up, then we'll see. And actually, what's super interesting, I think, from his assessment was he's got a better knee to wall on that side. He's got more calf muscle on that side, and he's got a better heel raise on that side than he has on the other side. So there are lots of positives to give him to say, look, you've done really, really well, because actually you probably started, I haven't got the data to hand, but you probably got started where you are on the asymptomatic side. But it's just that this tendon is so thick and angry, and we need to get out of the cycle of being able to do 6 months. Ideally it would be maybe move away from running if you're not going to do it consistently. But that's a decision that he's got to make. But he still needs to be active, and he's still, he's doing a lot of steps from his tour guide work. And you want to give him the opportunity to be able to run. So I think that's interesting. But again, those insurance companies don't necessarily recognise it, and he can't have physio and shockwave at the same time, which is not ideal. But at least he's got a good program. But if I send him to see a good physio who subspecialises in running related injuries, he can get some input there whilst also having the shockwave. So hopefully that works for him. But again, you're navigating what insurance companies will cover, and that's difficult when there's so much variability, even with his own policy. That, as he would say, I spent a lot of money on this for a long period of time. Why isn't it getting covered? You're not proposing surgery. It's a relatively cheaper solution than big surgical intervention, which is not indicated in this. And so again, like those conversations you're having, you end up then having to spend a lot of time talking to patients around what's covered by insurance, what isn't covered by insurance. Everyone's policy is different, even if you're same with the same company. And more things now, particularly post-COVID, are dropping off the insured options. So actually, to be self-pay often can be better, because patients you pay for it whatever you go. So you say, well, this is the best treatment option you could have. Use Bupa as an example. They'll say, well, you can have a steroid injection and then it's straight to surgery. And you're like, well, hang on, there's a massive gap there in the middle of things that can be done, whatever the issue is.
I find that the most the most illogical way of thinking about things. They're much happier to spend many thousands of pounds on surgery versus authorising slightly more expensive physiotherapy or slightly more physiotherapy sessions. And those extra physiotherapy sessions in many cases could prevent surgery completely. And that's the bit that seems completely illogical to me, that they look at the investment in a very strange way, because once they've had surgery, they then authorise the physio on the other end of it anyway, on the whole. It just doesn't really make logical sense to me, the way these insurance companies make their decisions. Yeah,
it's frustrating to see the frustration that patients go through, and that you just know you're going to have again and again and again. And it's a bit like any sort of navigation at sea, if you like. Everything's moving all of the time, and it is frustrating for patients, but also for practitioners as well, to work out the best way to help that individual in front of you.
I think another classic tricky one for physios to manage is arthritis, and the reason I find arthritis can be hard is that it is a forever condition structurally. Once the structure has changed, it's not going to you're not going to grow more cartilage. I do now believe that you can change that cartilage from a deconditioned load intolerant cartilage to a load tolerant cartilage. I think you can change its inherent ability to handle some load, but you can't. It doesn't get thicker. Use the meniscus, for example. You can't have a significant degeneration of a meniscus and then it grows back. It doesn't work that way, certainly unless anyone can show me otherwise. So then our physio's way of dealing with things, we strengthen up the muscles around it. We try and build up their load tolerance gradually over time, and we educate them on flare-up management and go from there. But often that doesn't give us the results that we're looking for, and people flare up maybe for longer than we hope, or they flare up and lose some confidence. They struggle with that, and they're then, I think I need a scan, I think I need to see a doctor. Absolutely fine by me. I think that's a perfectly sensible indication for that. So someone walks into you, they have arthritis in their knee perhaps, or any other joint. What are the thoughts on your mind? What kind of investigations and medical interventions might you be considering?
Yeah, fine. Okay, so if we're just going to talk about knee OA, knee osteoarthritis, there's obviously lots of things that the patient can do lifestyle-wise to reduce that, as you've mentioned, in terms of building up strength, and that could be weight loss, could be more low-impact activities. Biomechanics are very important when it comes to knees, and so looking at what that alignment looks like, looking at their walking gait, do they need orthotics, those types of things are important. Baseline imaging is helpful, and depends therefore what may be best for that individual. Some people just want to have an X-ray, but obviously the MRI is going to give you much more detail than that. But you don't necessarily need to do an MRI. Some people don't want to have an MRI. They don't like the method of being enclosed for 20 minutes to have that scan. But ideally, those are the two main modalities that you would be looking at. But as I always say to patients, that's going to give you one answer. It's that the history element, the function. What are you able to do? What can't you do? What's your biggest issues? And if you can get them to starting to do some engagement with physios and do some low loading activities, cycling, rowing, swimming, something they enjoy, just to get them moving, it's going to have a benefit. Because the other thing that people, I try to get patients to think about is, it's not just about your knee. There's the whole body that goes with it. And what else are we doing to work on you? Because if your knee goes down and you start putting weight on, then your cardiovascular risk goes up, your diabetic risk goes up, your respiratory health declines. There's potentially, an impact then on your mental health and all that goes with it. So trying to keep people moving then becomes important. And then from a doctor's point of view, if we looked at all these health and lifestyle things, which physios often will talk to patients about as well, it doesn't have, and it's often best if more people are talking to about it, because you've only got so much of a snapshot of time with patients, and it needs to be a whole medical society piece, and physios are important with that because they've often got a longer term relationship with the patient already, because, as you say, once osteoarthritis has started, it becomes a progressive issue, and if you've got it in your knees, you've probably got it somewhere else as well. And you may have been seeing that physio off and on for a long period of time about other issues as well. So physio is a great space to help support that patient. And then you're into injection therapies primarily. So the main ones really being steroid, hyaluronic acid, PRP, a combination of hyaluronic acid and PRP potentially, and then the newer arthrosamid injections. And again, there's a stepwise approach, and there's pros and cons to all of them. Depends how advanced your arthritis is at the time of presentation. I think, in terms of where people come and see myself, if you like, or doctors. And, steroid can be helpful. I mean, I had a lady this morning who came in, she's in her mid-60s. She wants to go on this, it sounds epic actually, this walking holiday in Bhutan. It sounds brilliant. And she wants to do it at the end of October. But she's just done something more recently to her knee in another walking holiday in Norway. I was like, wow, you're really engaged in these walking holidays. It's great. But her husband's had a knee replacement a year ago, and he's doing okay. He's getting back into moving, but she doesn't want the downtime that surgeries would cause her. And I said, okay, well, looking at your knee, you're most likely to have moderate to quite advanced OA. You're in your mid-60s. You can see, you've got some osteophyte formation there. You've got an effusion. You've got some joint line tenderness. Probably going to be grade 3, grade 4 cartilage change. We can do something to help you get through your holiday in a few weeks' time, but then we need to be thinking about the longer term solution. So for her, it potentially may be a steroid. Hyaluronic acid is probably going to be ineffective because not all hyaluronic acids are the same. Some are very good at supporting from a shock absorption point of view. Some are very good at lubricants. Some sit in the middle. I think hers would be too advanced for that, or certainly her activity levels would be that she wouldn't really want that sort of thicker, heavier hyaluronic acid in the knee. And she could look at PRP. That could be an option. Certainly the way that's quite an exciting space in terms of the way things are changing, where the traditional series of 3 PRP injections have been overtaken by the newer devices which concentrate the leukocytes even more, and so you can get a higher concentration now in a small dose and just have that as a kind of one shot. So that's an interesting sort of advancement, and again that could be something that she might look to do, or then she's into the realms of arthrosamid. But we're doing the MRI, so we'll wait for those results to come back. But those are types of conversations that you can have with patients now, and all of that is a conversation for you to, as a practitioner, you give them the information, they then think about what's going to be best for them, and after that you're going to be going back for more physio and more strength and conditioning work, really.
Let's pick up a few things there, actually, some really good stuff. Firstly, this idea of sometimes the patient just needs to hear the same message from a different person. I really believe that. I think about it in my own practice anyway, this communication idea of, if there's a really key message, I'm going to keep saying it. This idea of like this nail, you've got to keep hammering the nail in before you deliver the point successfully. If I've got something really important to say to them, if I just say it once, I don't think the message lands quite well enough. And we know how much patients forget anyway, so we have to, if there's something really important, I want to make sure that it's the thing they go away with. I might write it down as well, I might send them some resources around a key point. If they then go and see a doctor who says the same thing, how powerful is that? Oh wow, it wasn't just my physio saying it, it seems like even my doctor's saying the same stuff again. And perhaps sometimes that's even around the, you were mentioning around how knee OA can drive health change. But actually, it might even be the other way around, right? I'm sure you kind of see this a lot, where it's the health that maybe they're overweight, maybe they're systemically unhealthy, and that drives the systemic inflammation, which then drives the OA itself. So it almost works the other way, the causative way. And that's the bit that I think sometimes people don't fully get. They see OA as this biomechanical load problem, and what they're seeing now actually, that weight loss in those cases is working across two factors, biomechanically as well as physiologically. Less systemic inflammation, which reduces the osteoarthritis inflammation itself, which leads me quite nicely into that arthrosamid and steroid conversation here, which both of those are working with inflammation in one way or another. And the listeners will know that I've worked with arthrosamid for a few years now, and we've helped them with their aftercare rehab, their free rehab plan online. And I find it a really interesting avenue and a really interesting progression within this space. Could you just tell the listeners then the difference, or the times when you're thinking about, because you mentioned there in that case how steroid could be something that helps in this particular phase for this patient, and maybe arthrosamid might be something after they've got back from their walk. Why are you thinking in those terms? What's the differences for those two things?
Yeah, sure. So, firstly, the lady's presenting and she's got her performance timeline is to go on this walk, which is only going to be for 2 weeks. She's not going on an expedition to the North Pole, but she's going on a nice 2-week holiday where it's going to be a lot of heavy walking. And so she needs some immediacy, which is what steroids going to give you, but it's only going to be short term. So it's going to work within a few days. You'll have a good effect by the time you're at 2 weeks. She's not going on this trip for a few weeks, so she'll have a nice period of time to be able to build in the UK for it. But then it's going to wear off quite quickly. I quote patients around 6 weeks time that it's going to work for. Some people may get a little bit longer of a positive benefit from it. Not necessarily that the injection itself is still working, but you've been able to push past the issue because maybe you've engaged a bit more with your physio by reducing the pain. But for something like this, she's not had injections in the past for her knee either, which is also an important thing to say. So there is definitely a diminishing return on steroids, and generally I would say to patients, look, the first one's your best one. Wherever we're putting it, we're talking about knee OA, but it's the same for other issues. And so we need to really focus in on our rehab to make the most of that. Certainly by the time you're into sort of second or third injection, you're not doing very much, and it becomes damaging for the cartilage as well. So you don't want to be doing that. And also it's quite a good indicator for arthrosamid. So where arthrosamid is really working at reducing the inflammation within the knee, that's primarily what it's doing. If you get a good response from the steroid, it's more likely that you're actually going to get a good response or a better response from arthrosamid. But arthrosamid does take 3 months to fully integrate with the system and therefore delivering a response. And so for her, it wouldn't be appropriate to do that knowing that she's going to go on a big walking holiday, because whilst the data would say 1 in 5 people get knee swelling in the first few weeks with arthrosamid, I just tell all patients expect that it may swell, because then they're not surprised and they're not worried if it does. Again, we can always reconnect and work with the physios on that. So managing expectations and what's appropriate, thought process for her. But as I say, PRP was an option there as well, and that may be appropriate for her once we've got the results back. But yeah, you got to look at the time frame windows. And so again, go back and over the winter of this year, I had lots of people coming in inquiring about arthrosamid. They'd essentially read about it, maybe over Christmas, if you like. They were coming in and they were thinking it was an appropriate thing for them. But I also knew that a lot of these people were then going skiing. So I said, well, actually, no, what would you normally do going skiing? Would you get a hyaluronic acid? Would you have a PRP? Would you have, any other form of combination of injection? They said, oh yeah, I'd normally go and have a hyaluronic. And I was like, okay, well, probably it's better therefore to do that, because if we give you an arthrosamid injection, your knee swells in the first couple of weeks and you're skiing in 2 weeks' time, you're not gonna thank anyone. So a lot of them had something to get them through that period of time, and then they came back Easter onwards to then have their arthrosamid be able to do their rehab. So you've got to work with the patient, but also appreciate what the product is going to do and can do, and what that journey of recovery looks like, to help manage their expectations so that they get a good result from it.
And what outcomes are you generally seeing since starting to use it? I know you've been using it for a year or so now. A couple of years.
So we've got really, really good results. We've been using Patient Watch to collect our data. So it's fed in by the patient at baseline, 3 months, 6 months, and then every 3 months after that. And we've shown on our WOMAT scores that the combination of good physio and good rehab plus the injection in an appropriately selected patient is getting better results than even actually arthrosmid have got, which is really encouraging. And so you get that big hockey stick change on your graph, so a big drop off in pain and function, which then lasts. And other people are getting that as well, which I think is encouraging. I think if you look at the orthopaedic work that was done with Prof Snow, he's presenting similar NHS data. So it's good to see that actually people are getting good results. But it's that combination of choosing an appropriate patient, managing their expectations, giving them really good instruction on how it may respond and how it may be for them, and then linking in with some good people for the rehab point of view.
Yeah, and look, the common theme of this whole episode has been about collaboration, hasn't it? Sports medicine is a team game. It's a great phrase here, and I think that the main thing is that you can help us to understand different things in different ways, but if we all work together, we get the best outcomes for the patient. That's really what this is all about. Another tricky one that I think that we get stuck with as physios is dealing with inflammatory pathology. I know a bit more about it these days, but probably the first 5-ish years, I'm not sure I'd have picked it up. I'm sure there's loads I missed because there's a bit more to it, or there's a nuance to it. So if you've got any cases you can think of, you could speak us through or help us understand a bit more about inflammatory pathology in general.
So one of the really interesting things about working in that Headley Court environment was the fact that they have rheumatological clinics that mainly focus around the zero-negative arthropathies, and then they bring people on for residential rehab for a week. And so they get to meet like-minded people in terms of they're all military, but they've also got a similar condition, and it affects people in different ways. But also they can really focus on not just physio, but strength and conditioning work and mobility pieces and other management of their condition, which is a lifetime issue. But when well addressed, they can be super high functioning and then be able to live out their military career and all the other sporting activities that they want to do. So I think, I mentioned this before, gout, for example, it doesn't always necessarily read the textbook. It isn't always in your big toe. We see more of it outside of that area. And again, I had a patient in this week who, in their mid-30s, has this alternating sacral iliac joint pain, slightly worse than night. And these are, she's thinking it's a back pain issue. She's seen a chiro, she's seen physio, she's had acupuncture. She can't do Pilates, which is the main thing that she likes to do. She's had it for 2 months. It's non-traumatic. It's like, well, this is like when your spidey sense starts going off and you think, we don't need to dive in and do the blood straight away. Let's just get the MRI imaging first. Let's speak to the right radiologist. Let's perhaps speak to a rheumatologist. But I think it's shaping up to be the main thing that we need to rule out. This is not purely just a musculoskeletal issue. There's more potential underlying rheumatology. Picking up with this afternoon, so I'll let you know next week.
Yeah, well, the thing that really helped me in my practice was the SCREEN-DEM acronym. Is you can, if you just type in screen DEM in Google, it'll show up with this list of things to ask the patient. And because I don't see enough of it, because I'm not in rheumatology, every time I'm suspecting there might be something going on with it, an inflammatory pattern of some sort that doesn't quite fit a more traditional musculoskeletal injury, I literally type into Google, just bring it up, and I even show the patient. I'm like, right, I've just got this. I just want to check through this, and I speak through all the list. Does any of those, a positive finding? And if there's one, maybe I'm not going to rush into it, but I'll keep it on my mind. But if there's sort of 2 or 3 or maybe more of those that come through as, oh yeah, that's me, I'm going to send them off. I'll send them off to someone like you because it's not my world. And I've picked up a few in my career where it's been early enough where, it probably catches it at a really great time for them to be able to live very normal lives like you've described.
Yeah, I think that's a sort of, it's a really interesting thing about what we do. Obviously a lot of the people that come in are fairly barn door. We know what's going on, what the problem is. but you do get these, you know, atypicals, if you like, and you know, you never know when that's going to be. But there's also a lot that you can do for these people, which is great. But it is about, again, we go back to it's a team game. You've got to bring the right people in to make a big difference. But I've seen that in my career in these other elements, like military rehab, or like in these high performance sports environments, where you can really make a good positive impact on that individual for, you know, the long term.
Yeah, I think it's really powerful. I think the theme really is kind of get out of your comfort zone, get out of your silo, and build a network, and make sure you've got at least one musculoskeletal doctor, sports medicine consultant, however we want to be calling it. I really love that musculoskeletal doctor title. Anyway, find someone that you can work with, because if they're not next door in a room that, luckily enough, I used to have, that someone who's willing to be on the end of the phone and answer some messages and some questions, because not everyone will be able to fund it. Not every patient will be able to afford it, but you at least want some of their knowledge to be able to use and learn from, to support optimal patient care. But ideally, just really encouraging that value proposition that this is valuable for your health here, that we have a team around you that's supporting your ongoing recovery. Is there anything that we've not spoken about today that you think is relevant to our conversation?
There probably will be. I'll think about it when I get home. But no, I think it's great. I love it when people try to connect with you, whether that's they send you a message on LinkedIn, or they send you an email, or they want to come and see you in clinic, or attend one of your events that you're organising. I think there's a great opportunity to, like you say, you know, collaborate or learn from each other. And I think the more that we can work together, the more fun it is. Like, you don't want to, you know, work shouldn't be hard. You know, you can make your life easier by working well with other people. And the more that you do that, I think the more you're engaged, the more you learn, and the more enjoyable your working life will be, as it were. And you meet some great people along the way.
Yeah, I think there's sometimes this fear around, so certainly speaking from my younger physio experience, being a little intimidated, maybe imposter syndrome around doctors, and thinking they're up on this pedestal, there's this hierarchy, doctors sit at the top. I strongly disagree with that concept now. That I think that physios are expert in our musculoskeletal rehab world, and doctors are expert within their medical world, and we share ideas to create the best level of care for the patient, that team environment again. So I no longer feel that way, and that's probably an age thing as well. But yeah, get out there and meet doctors and speak to them. They're just as interested in what you're doing on the whole. And if they're not, they're probably not the right person for you. You know, you can find someone who genuinely wants to collaborate. My final question to you, what does Better Never Ends mean to you? It's a big part of our podcast. It's our main tagline.
Well, I think others may have already said this, but it's that constant evolution, isn't it? It's, you know, thinking about, you know, I mean, maybe not on an everyday basis, but maybe I always try to reflect at the end of the week, you know, what have I learned this week? What went well? What didn't go so well? And therefore just thinking about, hey, what can I do differently next week? Maybe it's not necessarily going to help me, but it might help someone else that I'm working with just to do their job a little bit better. And therefore, how does that then positively impact on a patient outcomes, if you like?
Yeah, very nice. And how does someone find you, George?
LinkedIn's easy. That's probably the easiest one, because or you can just randomly Google me. Yeah. There's not too many George Bownes out there.
Yeah, very good. Thanks so much for the time today.
Thank you.
Thanks for listening to today's podcast. This podcast is sponsored by Better, provider of health and wellness services in central London. We really believe that we can help people feel better and live better. You can book in for face-to-face services at any of our 3 London clinics. We have one in Marylebone, one in Soho, and one in the city. You can also follow us on Instagram at Better Never Ends, or head over to our website for more information about the clinics or the podcast at www.betterneverends.com.